Thank you very much, Irene, and thanks to the organisers for asking me to come and speak here. And it's very nice to come to somewhere warm after leaving the United Kingdom. And Professor Keogh and I are going back to, I think, -3 degrees on tomorrow evening. So make the most of Athens. So I'm going to talk about the customising HRT in terms of what it does to cardiovascular disease and venous thromboembolism. There's my disclosures. So if you look at the way that hormone replacement affects coronary heart disease, then it has effects on a number of different risk factors for coronary heart disease. I'm not going to go through all of these, but I will go through some of the major findings. So if you look at lipids and lipoproteins, then all forms of HRT, all estrogens, and it doesn't matter which progestogen you add, will decrease total cholesterol, and that's because all of them will decrease LDL cholesterol. But it depends on the type of progestogens particularly that you will either get an increase or a decrease in HDL cholesterol and an increase or decrease in triglycerides. And I'll show you this a little bit in a few minutes. But there are other effects of HRT as well. HRT will decrease lipoprotein little a, which is in its own right a risk factor for coronary disease, but only when the LDL cholesterol is elevated. So that's when lipoprotein little a becomes important. And estrogen will do other things as well. It'll increase the clearance of atherogenic particles. It increases the clearance of the small, dense LDL particles, and it increases the clearance of the chylomicron remnants. And it also protects LDL against oxidative damage. So these are important sort of qualitative effects that HRT will have. So if we look at the effects of different estrogens and different routes of administration on the lipid profile, then what you can see is that they all reduce total cholesterol, but the oral therapies are more effective than transdermal therapies in terms of reducing LDL cholesterol. And they're more effective in terms of increasing HDL cholesterol. And there is a suggestion that the conjugated equine estrogens are probably a little bit more effective than estradiol 17 beta. But when you look at the effect on triglycerides, which is shown at the end of the panel here, then you can see that the biggest increase occurs with conjugated equine estrogens, a smaller increase with estradiol 17 beta. But when you give estradiol transdermally, it has the opposite effect, and you actually reduce triglycerides. So you can choose which type of estrogen and which route of administration to affect the lipid profile as you wish. When you add a progestogen, then this will have an impact on the effects of estrogen. So on the left-hand side here, you can see the effect of conjugated equine estrogens on the lipid profile, reducing LDL, increasing HDL, increasing triglycerides. But if you add then an androgenic progestogen, such as norgestrel, as shown in our study here, then you can see that it actually doesn't affect the lowering of LDL, but it stops and even reverses the increase in HDL. But it also does the same with triglycerides, so it stops the increase in triglycerides. So there's some good effects there, but some bad. If we look at medroxyprogesterone acetate, and if you remember that this is the progestogen that was used in the Women's Health Initiative, then again you can see that it blunts the increase in HDL that is seen with estrogen alone. So medroxyprogesterone acetate actually does have some androgenic properties, and that's why it has this adverse effect on the lipid profile in terms of reducing the HDL increase, and it doesn't reduce the increase in triglycerides. So hydroxyprogesterone acetate is not a particularly good progestogen in terms of its metabolic effects. You may be aware of the idea of replacing progestogens with beta-doxephene, and this has been marketed now as a combination therapy. So you've got conjugated equine estrogens plus beta-doxephene, and certainly very effective in terms of preventing any postmenopausal bleeding and protecting the endometrium, just like a progestogen would. But when you look at the effects on the lipid profile, again, no impedance of the lowering of LDL cholesterol, but you can see it's blunting the increase in HDL cholesterol quite effectively. And so it's really acting like an androgenic progestogen in terms of its metabolic effects on lipids. If you look at a non-androgenic progestogen, and either micronized progesterone, or in this case, in our study, looking at dydrogesterone, which is very, very similar to progesterone, then you can see, again, no impedance of the lowering effect on LDL, but equally, it does not blunt the increase in HDL cholesterol. So this progestogen allows the increase in HDL that is induced by estrogen administration. And you can see in this study we saw a nice lowering of lipoprotein little a. Okay, so that's looking at lipid effects. Let's now look at effects on glucose and insulin metabolism. And here we see a difference in the different types of estrogen. So conjugated equine estrogens, at the standard doses we use today, below 0.625 milligrams, really has very little adverse effect on glucose tolerance. But above 0.625 milligrams, you can actually get some impairment of glucose tolerance, and it causes an increase in the insulin response to a glucose challenge, which we would regard as an adverse effect. But in contrast, if you look at the effect of estradiol 17 beta administered orally, you actually get an improvement in glucose tolerance and a decrease in the insulin response to a glucose challenge. If you give it transdermally, then really it's a fairly neutral effect. But again, the problem with progestogens, if you give androgenic progestogens, then they will increase insulin resistance. So giving androgenic progestogens orally, you get an increase in insulin resistance. If you give them transdermally, as we can do with norethistron acetate, then that has really very little effect, so it doesn't have much of an adverse effect. But again, medroxyprogesterone acetate has a very adverse effect on glucose and insulin metabolism, whereas micronized oral progesterone or dydrogesterone really have no adverse effect at all. And so these are important differences, again, between the different types of progestogens. And if we look to some of our studies looking at insulin sensitivity, so that's the opposite of insulin resistance. And you can see on the left-hand side the application of transdermal estradiol has really no effect on insulin sensitivity, and adding transdermal norethistron really makes no difference. Whereas with oral estradiol, you can see the big improvement in insulin sensitivity, but when you add the androgenic progestogen norethistron acetate, then you prevent that improvement in insulin sensitivity, so it actually impairs it. If, however, you give dydrogesterone, a non-androgenic progestogen, and this is looking at oral glucose tolerance tests, you can see that there is no change in glucose tolerance during the 2 years of this study of ours, but there is a steady decrease in the insulin response to the glucose challenge. So in other words, the insulin action is becoming more effective with the addition of with the estrogen plus dydrogesterone. So you're not getting an obvious increase in insulin resistance with this progestogen. We look at blood pressure, then usually there is no effect or even a slight decrease in blood pressure when you put people on HRT. The effects will vary with the type of progestogen that you use, and those progestogens that have any anti-mineralocorticoid effect will produce more of a reduction in blood pressure. An increase in blood pressure with HRT is incredibly rare, very, very rare, and I've never seen it in all my years of practice. It occurs as an idiosyncratic response, and it seems usually, in the very few reports we've had, to be associated with conjugated equine estrogens, and it's a very early event. So if you put somebody on HRT and their blood pressure is normal, then check it again after 3 months. If the blood pressure has gone up, then it may be due to the HRT, but if it's not gone up, and then 3 years later the blood pressure starts to go up, you can be quite confident it is nothing to do with HRT. So the cardiologists that say, oh, your blood pressure's gone up, you must stop the HRT, that's absolute nonsense. And you can give HRT to anybody who's got raised blood pressure. You don't have to hold off giving HRT, just simply treat the blood pressure at the same time as giving the HRT. So these are data from a study looking at a progestogen with anti-mineralocorticoid effects, and this is estradiol plus drospirenone, and you can see the small decrease in both systolic and diastolic blood pressure in this study with estradiol alone, but when you add the drospirenone, you get a much bigger decrease in the blood pressure. So this is just an example. If we look at the effects on hemostasis, then oral estrogen does reduce some of the prothrombotic factors. It reduces fibrinogen factor 7, and it reduces plasminogen activator inhibitor 1, but it increases thrombogenesis. Oral estrogen increases coagulation activation, although perhaps at very low doses you may reduce or avoid this effect. We're not sure, and we're currently doing the study to look at this. But transdermal administration is absolutely neutral in its effects on hemostasis. And if you look from these data from Pierre-Yves Scarabin in France, you can see that the increase with oral HRT, the increase in venous thromboembolism, is seen early on. It's seen in the first year of use, and then this effect seems to disappear with time. So it's very similar to the effect that you see with oral contraceptives on risk of venous thromboembolism, that it's increased when you first go on, but with time that effect wears off. And there's also a dose effect, that the higher doses of estrogen will have more of a risk, and the lower doses will have less of a risk. But if you look at the effects in terms of venous thromboembolism of transdermal application of HRT, then you don't get any increased risk of venous thromboembolism like you do with oral HRT. And this is actually true even if you give transdermal HRT to people at increased risk of venous thromboembolism. You don't get any further increase in risk with the HRT. So an important thing to bear in mind that if you're concerned about risk of venous thromboembolism and you want to give HRT, then it's best to go for a non-oral route of administration. And lastly, just to look at the effects of estrogens on arterial function, and they have very, very good effects. You can see that estrogen, it induces nitric oxide production. It reduces the release of the very potent vasoconstrictor endothelin-1. It inhibits calcium channels and enhances potassium-dependent channels. So both of these actions are vasodilatory, as is, of course, is the effect on nitric oxide. And if there's one thing you need to know, you don't need to be a cardiologist to know about coronary heart disease, but the only thing you need to know is basic rule that a dilated artery is a happy artery. And if you know that, you know as much about vascular disease as any of the cardiologists. So HRT, or estrogen rather, is having a vasodilatory effect. It also reduces the activity of angiotensin converting enzyme. It reduces smooth muscle proliferation, and it probably has beneficial effects on vascular remodeling, at least at normal doses. And I'll show you a slide on that. So if you look at the effects of HRT on vascular function, these are some studies from Marco Gambacciani in Italy, then you can see that both estradiol alone and estradiol plus dydrogesterone has a beneficial effect in terms of improving hyperemic responses and improving flow-mediated dilatation. So evidence that HRT is actually having beneficial arterial effects. If we look at the effects on matrix metalloproteinases, which are very important for vascular remodeling, then there's some data of ours looking at smooth muscle cells, vascular smooth muscle cells in culture, and we showed that there is actually a dose-dependent effect of estradiol on matrix metalloproteinase, so that at low doses you'll get an improvement in vascular remodeling. But at very high doses, you actually might get an adverse effect through excessive remodeling and destabilization of existing atheromatous plaques. So a low dose, probably good. High dose could be actually adverse. Let's just look now at some clinical endpoints. And this is a study we did looking at the effects of estradiol on ECG exercise tests in women who've got established coronary heart disease. So these are women with coronary heart disease undergoing ECG exercise tests, and you can see that when you give them estradiol as compared with placebo, there is a significant improvement in the ECG exercise test. It takes longer to get evidence of myocardial ischemia, as shown by ST segment depression, and the women are actually able to exercise for longer before they start getting symptoms of angina. So that's just a demonstration of estrogen being beneficial for myocardial ischemia. If we look at endpoints such as coronary events, then if you look at the data from the Women's Health Initiative, which you may remember their first publication of the preliminary data in 2002 claimed that there was an increase in coronary heart disease events, and this turned out to be totally wrong, because with the full data there was not an increase in coronary events, and indeed with estrogen alone there seemed to be a decrease in events, and with follow-up of the Women's Health Initiative, for those women initiating HRT below the age of 60, there was actually a significant decrease in coronary events compared with placebo. And yet when they first published their data, they said that there is harm from HRT, and they also said there is no effect of age at initiation. That's what they said, and yet with their later publications showed that that was completely untrue. These are data from the Danish osteoporosis study from Louise Scherbeck and colleagues, looking at 1,000 women who are taking part in this study in their early postmenopause. So the average postmenopausal age is 7 months, 7 months after the menopause, randomized to either oral estradiol or to no treatment. So it's not a double-blind study, it's an open-label study, but it is randomized. And the trial went on for 10 years. They stopped it when the WHI data were first published, but they carried on observing them for a further 6 years. So you've got quite a long follow-up in this study. And their primary outcome that they looked at was a composite of coronary heart disease events death from coronary heart disease, or admission to hospital with heart failure. And that composite event showed a significant decrease with the HRT compared with no treatment. And of interest, if you look at the bottom line there, that with 10 years worth of treatment, they saw no increased risk of stroke, of venous thromboembolism, or of any form of cancer, including breast cancer. So this study says that 10 years worth of HRT does not increase any of these potential risks. If we look at meta-analyses of HRT and coronary heart disease events, then these are data from Shelley Salpeter and her colleagues in California. She's a general practitioner out there who seems to spend all her time analysing other people's data, so what time she has to see patients, I have no idea. But it's very useful data, so you've got here data from nearly 40,000 postmenopausal women. And if you divide them into the time, the age at which they initiated their hormone replacement, then you can see that starting HRT below the age of 60 or within 10 years of the onset of menopause, there is a significant reduction in coronary events. Starting or initiating the therapy above the age of 60 or beyond 10 years post-menopause, then there is not a reduction in events. But equally, there is no increase. So you're not causing any harm, but you're just not seeing the same benefit. These are data from the Finnish National Register, and this is looking at coronary heart disease death. And I always think that death is a great endpoint to look at because nobody can argue with it. You're either alive or you're dead. You know, there's no question. And what this shows, again, a huge study, 90,000 postmenopausal women starting HRT below the age of 60, there is a significant reduction in coronary heart disease death. Starting above the age of 60, there is not a significant reduction. There's a small reduction, but it's not significant. But equally, there's no increase in coronary heart disease death. So no harm, even if you're starting above the age of 60. But it just emphasizes how important the timing hypothesis for HRT is, that you'll get the best benefit if you start below the age of 60 or within 10 years of the onset of menopause. You may get benefit at later ages, but that's probably to do with dose of estrogen. And lastly, just to look again at the Finnish data, when you stop HRT, then during the first year, there's actually an increase in coronary heart disease deaths. There was also an increase in stroke as well. But after 1 year, that increased risk has disappeared. So it would fit in very nicely with a direct vascular effect that when you stop the HRT, there is an impairment of vascular function and an increase in coronary heart disease deaths. And lastly, just to mention stroke, these are data from the United Kingdom General Practice Research Database, and what it shows is that there is a small increased risk of stroke with oral estrogen and with high-dose transdermal, but with standard dose transdermal, there is no increase. And in fact, what this study showed was that you don't see any increase in stroke if you initiate HRT below the age of 60. And again, it comes back to a dose effect. Just a few practical suggestions. In postmenopausal women, then women who are at increased risk for coronary heart disease may well benefit from HRT, although it's not a licensed indication for its use. So we are told we mustn't use HRT solely for the prevention of coronary heart disease. But if you've got a woman who you think is at increased risk for coronary heart disease, then HRT is certainly going to be beneficial. Try and find a reason if she's got another indication for HRT. So in my outpatient clinic, I say, have you had any hot flushes? Have you ever had a hot flush? And if they say no, we simply turn the heating up in the clinic until they have a hot flush, and then I can give them HRT. The important thing is be very aware of the dose that you're going to start them on. depending on their age. So below the age of 50, we'd start them on a standard dose of estrogen. Between the ages of 50 and 60, we put them on a lower dose, say, so 2 milligrams or 4 milligrams before the age of 50, 1 or 2 milligrams of oral estradiol between 50 and 60, and beyond 60, we're going to be looking at 1 or even 0.5 milligrams of estradiol. And do remember, in premenopausal women, there are situations where you can also get benefit from giving estrogen. In premenopausal women who basically are immune from coronary disease to a large extent, but they may get microvascular angina, and these symptoms always occur, or virtually always occur, in the luteal phase of the cycle. So getting angina, getting cardiac dysrhythmia in premenopausal women almost always occurs in the luteal phase of the cycle when estrogen levels are falling. And if you give them a top-up dose of estrogen, then that will often help relieve these symptoms. So it's always worth bearing in mind. So in conclusion, I think that the totality of data we now have for HRT indicates that it is beneficial for the primary prevention of coronary heart disease. And that's important because we don't have anything else that will prevent coronary heart disease in postmenopausal women. Low-dose aspirin doesn't work in women, although it works in men. It will not prevent coronary heart disease in women. It will prevent stroke, but not coronary disease. The risks for venous thromboembolism and stroke can be minimized by choosing the right dose at initiation of therapy and the right route of administration. And the type of hormones, particularly the progestogens, very important in terms of cardiovascular disease, that the non-androgenic progestogens are the ones to choose. And again, the importance of the starting dose is absolutely critical. Thank you very much.